Hi everyone, my name is Sahdev Baweja. I'm a member of SIGN here at New York Medical College, and today I have the privilege of interviewing Dr. Jin Li. She is the Chief Neuromuscular Section. She is the Medical Director of the Headache Service. She's Associate Program Director of the Neurology Residency, and we are welcome to have you.
Thank you so much. It's a pleasure to be here.
Yes. So to start off, Dr. Lee, could you tell us a little bit about your journey and why you chose to become a physician?
Okay, so I actually grew up back in China. So when I in China, the medical school system is more like a medical school system in UK. So when we graduate from the high school, we choose either directly go to medical school or any um, or it's basically part of the part university. You already started to your medical school right after the high school. So the reason I choose medicine, I think that time I really quite influenced by my family. And I remember my parents always tell me, oh, in my family, we needed somebody to be a doctor. So when we become older, somebody can take care of us. Of course, in the Asian culture, it's really instilled in our value system. You got to take care of your elderly. And I think become very natural to me since I was instilled when I was very young to be a doctor. So I can say I always want to be a doctor.
Yeah, that's
That
definitely a thing. Um, so were there any specialties you were considering, or were you always wanting to become a neurologist, or what led you to become a neurologist?
yeah, when I was in China, that's back in the 90s, it's quite become a trend when people well in the medical school at that time, uh, people have a different pursuits, want to have a better life. And it's really a lot of a good students started to take GRE and to try to enroll in medicals into the program in US. At that time, actually, when I um, studied in medical school in China, I did not know I was able to, if I come to US, I'll be able to continue to be a physician. Um, but nevertheless, to pursue for a better life. And I basically, with my friend, we started to do the GRE and apply the PhD program. That's how I actually landed in the US. Interestingly, when I applied all the graduate school at that time, I applied around Northeast, basically, from Boston to New York, since we have many. My friends are here, and of course, look at the ranking of different schools. What is school is good at what field. Anyway, I landed in New York Medical College, actually with the cell biology and anatomy department. At that time was Dr. Adlinger, who actually accepted me, and he is still the chair at this time after all these years. So that was I was accepted here as a PhD student in cell biology department. That's how I started my journey in US. And while I was working on the PhD thesis, and certainly, the desire become a clinician, back to the field taking care of patient, um, that came back to me. That's how I went to take step one, step two, and well, I was a PhD student. That's how I end up back to the residency program. It was interesting when my PhD thesis was studying ubiquitin isopeptidase. At that time was actually quite still very was say it was a novel. Ubiquitin is still at that time was novel, was not in the textbook. Scientists start to realize ubiquitin is very important for protein degradation. And our motto was really talking about neurodegenerative disease and applying my PhD study on the neurodegenerative diseases. That's how I linked my basic science research to the clinical work to neurology. That's how my journey started. Actually, start the residency program right here at New York Medical College. So at that time, the neurology residency is still part of NYMC program, and now currently is WMC program. So everything seems to be natural, and that my PhD thesis also had the clinician as the supervisor, advisory faculty member. So that's how I get a connection here. And I did my residency here, right here in Westchester Medical Center. So that's how the journey started. I was trained as a neurologist.
Okay. And you said you hold many different positions, but you said you do neuromuscular and headache. So what led you to pursue those? And yeah, let's just start with that.
Mentor is always the key during the development, during the education period time. You always aspire. Whoever is your mentor, you really aspire at their work and how their work actually make a difference in patients' life. That's how I get aspired. I think at that time, my mentor, Dr. Francis Styro, who actually also graduated from the residency program, New York Medical College, many years back. And she actually knows Dr. Singh, Dr. Aliwalia, who is a pastor, who is actually currently is the chairman emeritus, and who was a chairman back then, and Dr. Ramani, who's an epileptologist currently. They all know each other during their residency right here. So she really inspired me. She was a faculty member here, and she was trained in Columbia as a neuromuscular specialist. So I really learned a lot from her, and she also inspired me to doing a lot of EMGs while I was a resident. And that's how I get interested in neuromuscular. That's how I continue on, basically continuing my work on neuromuscular. And while I was doing tons of EMGs, I know every muscles. So after I graduate and start my career as a neuromuscular specialist, and initially was a general neurologist, I starting during the practice, I do see during my general neurology practice, I do see many headache patients. And at that time, I also started to do the botulinum toxin injection for the various neurological conditions. And gradually actually accumulated many headache patients. And I say, since I'm seeing all those patients, at that time, the board certification for headache medicine was just starting actually at that time. So I was a grandfather basically, and I just took the headache board and become a headache specialist. So my current practice, I would say half and half neuromuscular and half of headache. So I'm very happy of my choice. Initial and it's really mainly the outpatient practice currently. But certainly this has been evolved over years. When I actually just started as attending here, uh, as a neurologist, we used to cover all the different services, half inpatient, half outpatient. At that time, there was not separated. There's no subspecialty as stroke specialist or neurointensivist. So we basically see all the um, neurology patient, either and in the neurology service or in the consult service or in the emergency room. At that time, it was really basic, just have a two team. One is inpatient team, another team is consult team. So everyone just rotating through, and half day was inpatient, half day outpatient. So with I certainly witness the development and the evolution of Department of Neurology from most are general neurologists, even has a specialist. Specialists also always see the general neurology. But now the department has evolved, has all the different specialists, and we have the neurohospitalist service. So everybody is kind of subspecialized and only see the patient on their own field. So, which is, I think, ultimately, certainly that's a trend, and patient get subspecialty care, which is certainly is really good for patient care. But I can see now I'm really, since my specialty, neuromuscular and headache, is really the outpatient focused. So currently, 100% outpatient.
Okay, so as you kind of touched upon, what conditions do you treat and what therapeutic options do you offer to your patients?
Um, Same thing, you can see the evolution, what had happened. Used to be, if we start with neuromuscular, we used to be really diagnostic, really have not much treatment. For example, myasthenia gravis now has been my favorite neuromuscular condition since it always has treatment, right? It used to be steroid. We always know steroid works 100% for myasthenia gravis. And then we have steroid sparing agent, we have isocyanates, and we have mycophenolate. So that's basically what we had before. Or over years, we start have the IVIG, plasmapheresis. That's just for the past few years. Now we have a really group. We have so many new medications, and we have the family of FcRn medications. Those are novel treatment. We have the complement treatment. Now, the first CD19 medication also approved for myasthenia gravis. So now myasthenia gravis is completely treatable condition, and we have so many can offer to the patient. And the clinical trial has been going on, and to use the CAR T. So think about it, it's really the neuromuscular, especially autoimmune neuromuscular disorders, really catching up with all the autoimmune neurology. We have so many we can offer to the patient. So that's the autoimmune aspect of the neuromuscular diseases. Also CIDP, that's another highlight for neuromuscular autoimmune disorder, have new treatment. As the FcRn have complement pathway treatment is all on the horizon. Same as AIDP, going to have a new medication as well. So there is so much development in the field of neuromuscular, especially the autoimmune neuromuscular diseases. Also, for the hereditary, that's the other part is my passion, MDA clinic. So we established Muscular Dystrophy Association Clinic. I think it was 7 years ago. And now initially we offered our expertise to the adult patient. So we do, at that time, there's no gene therapy. However, we have RNA treatment to treat the SMA, spinal muscular atrophy, right? And with the time evolved past 5 years, the whole field has changed. We're not only offering the exon skipping therapy. This is mRNA treatment. We all have the gene treatment. It's really changed the whole the disease, the outlook of SMA. At the same time, Duchenne muscular dystrophy. Now we not only have exon skipping treatment, we do have gene therapy as well. We had the IV gene therapy for the children with Duchenne muscular dystrophy, younger than 2-year-old. And the last year, just few months ago, the intrathecal treatment gene therapy for adult, for patient older than 2-year-old, all the way up to the adult patients. Now we have the gene therapy. So gene therapy become really the hallmark of the muscular dystrophy patients. So now our MDA care center not providing the treatment for adult patient. Now we also extend to the pediatric patient. So now our MDA clinic can provide the treatment to the whole spectrum. So I'm very proud of our center. That's for the neuromuscular. And let's talk about headache. That's another great field. You're probably fully aware of the CGRP, which has been the star for the past few years. And we have so many medications on the CGRP treatment we can offer the patients. They expand from the monoclonal antibody to the CGRP or CGRP antagonist. So they range from acute treatment to preventive treatment. Now we have oral treatment, we have sub-Q injection, even have IV infusion for migraine patients. So it's the whole spectrum. And we have the non-invasive neurostimulators for treating migraine. So it's really, there's a lot we can offer. So it's a great field to be in. Right now, it's really great to be in the field of neuromuscular diseases and headache medicine.
It's great to hear how much both fields have progressed and how many more treatment options you can provide to your patients. So how would you describe a day or a week in your life?
So I'm in the problematic career neurologist or advanced career neurologist, whatever you define it. So that certainly has been very rewarding career, I would say. Not only I think as a neurologist, when I choose as become a neurologist, I mean, at that time, neurology is more diagnostic specialty in a way. Neurology is a more laid back specialty. I think I remember when I was just still in the residency that the TPA was FDA approved. And yeah, at that time I feel I'm a more outpatient person. At that time I have the passion to do EMGs. And so that's how I choose this specialty, right? So I like to be both inpatient and outpatient at that time. So that's really that's how I imagine my career, um, how I practice neurology. And at that time, I got two children when I was a resident. We talked about that so many years ago. And so I thought it was a really good balance being a neurologist, taking care of both inpatient and outpatient, and also part of education, staying in the academic center, be part of the residency program, being a faculty, and do as administrative work. So it has been a pretty good balance. It used to be, I remember when it just started, it was half day in the morning. We make round, go to the hospital, make a round, and in the afternoon we come back to the office and see the office patient. We always have the Wednesday as academic day. So it has been busy. It's very busy, and it depends on the how busy the inpatient is. The outpatient, schedule can be adjusted accordingly. So it's used to be, I mean, even that from the beginning, the on-call schedule, it's quite different. At that time we cover all the service. I still remember one was a resident, I was the only one of the only neurologists in the hospital. So at that time, there's no acute stroke. There's no TPA. The TPA came a little later. So one, you do the LP, you see this emergency room, the patient. You're the only neurologist basically. Initially, we just started. Not sure about this, not sure about that. And one day it just came to me. It's like, okay, of course, as a senior last year, I was like, oh, I'm the only neurologist. Yeah. You got to listen to me, right? Otherwise, who else are you going to listen to? So like all of a sudden, I feel all the confidence is there. And I think that's kind of confidence just develop over time with the with the experience of the whole learning process. And so at that time, I become attending, on call. Yeah, really. I guess when you think about that time, it's hard, but it's you just feel you can do it. I think at that time, on call, um, and I think the question they're talking about the work and the life balance. Yeah, seemed to be balanced out. At that time, I remember even though I was on call, I was still able to go to, my kids, I have two daughters, go to their dance recital, go to their baseball game. You see, and they never stopped me doing those things, even though I'm on call, I just come early. I used to come 6 o'clock before they were up and make my round and then know all the patients and then go back to, go back home and they were up, whatever they're doing. You just say, um, you just kind of balance it out, make your schedule and just learn how to multitask.
And how has it changed since then?
Now it has changed a lot. Now we have so many different teams. We have the inpatient, we have the hot neuro hospital service, we have stroke service. Now I have the neuro ICU. As you remember, for the stroke service was the first one, the branching out, and that was really a huge. I think that's really changed the field of neurology. Neurology used to be always just lay back, give the diagnosis, and then. And there are treatments, but there's not like on time. There's no time is brain. That came later when the TPA came out. It's really become emergency. So that's really from brain neurology from the back burner all the way to the front. So that really make a huge difference. And become a neurology. And then all of a sudden, every hospital want a neurologist, right? Everybody wants to be a stroke center. And then with the TPA and then intraarterial thrombectomy, that's a second wave, right? And then now we got ICU after the patient now it's TNK used to be TPA. Patient need to be admitted to the ICU for 24 hours. I remember before we had the neuro ICU, those patients go to medical ICU, whatever ICU, surgical ICU, they all go to different ICU, and then develop the neurocritical care. Now we start have their own ICU, so everything changed a lot. So I used to, as everybody else, faculty, we take care of the stroke patient, post TPA, intracranial bleed, develop protocols. So I used to be a well-rounded neurologist, or any neurologists are well-rounded neurology. You see, I remember at that time our stroke specialists see the general neurology, and they even do the Botox, for the headache patient. I remember, our previous our stroke director, she does Botox for headache patients. Yeah, so everybody was so so well-rounded, can do everything basically. So now it's so different, I think, for the good and bad. So, we have more specialized. I think that's how advanced, that the field has been. Now we come kind of we used to be, when stroke just coming, I said, oh yeah, when neurology were after cardiologists, they did intervention, right? They did the intraarterial, now neurology is doing this. I think now neurology probably has already surpassed the cardiologists. I assume have so much more we can offer, more than cardiologists can do. The and the ICU, the same thing. Used to be. I still remember when I was the resident. They were like, "Oh, neurology, they cannot take care of ICU patient." Now, now was the at that time the medicine, the pulmonologists, I say that right on our face, but now it's totally changed. Neurology as a field. has advanced so much. We have so much to offer to our patient, for both inpatient and outpatient. So it's a great field. I'm glad you're interested in neurology. So I always inspire people to do neurology now.
Thank you. How do you see the field changing as we go further on?
Yeah, I think there's now so much we can offer, such as, for neuromuscular, for the immunology. Once I just came back the October from the ANEM, American Academy of Neuromuscular Disease, and Electrodiagnostic Association. That's basically for neuromuscular diseases. I was There's so many new medications I have to say for myasthenia gravis for CIDP. I was like amazed when I talked to, we're chatting. There's a lot of investor at the meeting. They're not only neurologists, not only scientists, they're investor. The VCs, the venture capitals are there. They want to invest on the neurology, the new medications. And I was like, myasthenia gravis is a rare disease. I was just joking. We have more medication than patient now. I think we're just following myasthenia gravis, the multiple sclerosis. That was so booming, so many different medications, right? There are so many of them. And with time goes on, only few kind of standing out become the really like the medication neurologists actually use the most. So I think myasthenia gravis field is kind of catching up with MS. There's really a lot to offer. The same thing. We go to the MDA conference, it's an annual conference, and that's another whole whole area at the gene therapy and has mRNA therapies and the symptomatic therapies. I think the most eye-opening is really the gene therapy. The best example is really SMA. Those kids used to they die before the age of 6 months. Now nobody die. Now it's really everybody survive. And now we're talking about, the most talking about was really the pediatric patients. They are transformed to become adults now because they survive now. You think about Duchenne muscular dystrophy. It used to be they would not survive until 20 years old, right? They die by the teen from the respiratory failure. Now they all live. And then when neurologists, the adult neurologists are not ready to take care of them because they only have a few of them. And then when those kids, they used to be kids, now become adults, and they encounter the whole different aspect of society, right? They're part of society. Now we talk about the whole different issue now, about their education, about their occupation, how do they become part of the society? They used to be just kids taken care of by their parents. Now we're talking about, when they survive, they there is their occupation, they what kind of job they're going to do, what the Disability Act can really helping out those neuromuscular patients who survive the childhood to not become adults. And there's a lot to need to offer to them. There takes a lot to take a team to really care about them, and they can be part of the society. Yes, definitely there's a lot evolving over years. This is a really big field.
It's great to hear.
Yeah.
Um, what advice would you give to someone who wants to become a neurologist?
I said, that's great choice. I think to be always curious. I think that's what you, and I think it's very important to expose to all the different specialty of neurology. I think now, um, everybody, not everybody. I think we're education, for the resident program now. Nobody become a general neurologist anymore. Everybody go to the fellowship. I think it's a trend, and they got to go to the fellowship to know more. However, in the field of neurology, we really need a general neurologist who can take care, who can basically have the basic knowledge. It's like internist because before they become a, GI specialist, become cardiologists, become oncologists. I think we really need the field of a general neurology, or now it's called comprehensive neurology. I do totally agree with this name. That's what we really need. When patient come with dizziness, we do have comprehensive neurologists to take care of them. I think that's the great field. And unless you have and this comprehensive neurology can take care of basic seizure patients. Only comprehensive refractory seizure patient has all those complicated syndrome, like Lennox-Gastaut, go to the epilepsy specialist. And this comprehensive neurologist basically can start with steroid for myasthenia gravis, right? And then probably sent to the specialist after steroid was started, um, and be a good diagnostician. Have the tools to do the initial diagnosis. And now we have the there are so many genetic disorder. Probably can link the dots from the many comprehensive complicated case, and the patients had the syndrome basically span all the different the aspect of neurology, or even more systemic, cardiac involvement, could be renal involvement. Think about the syndrome. Now I think neurogenetic, it's another great field. I think we're going to be all need those neurogenetics at the same time. I think now we have to bring back neurology as a whole, as the entire system, and to think about all together, and bring all the specialists together.
You kind of talked about how all the great progress that's made in the field of neurology, but what challenges do you think still remain?
Well, it's still a challenge. I think I probably touched the base about general neurology. I think we do need the comprehensive neurology, and not only the subspecialty. We need to be. I think many patients need need. We used to call it the gatekeeper. The PCP is their gatekeeper. We probably need a neurology gatekeeper as well, comprehensive neurologist who can, I think, was outpatient, probably equivalent to neurohospitalist, as the outpatient has the comprehensive outpatient neurologist. I think that area is still challenge. And also, I think thinking about neurologists who are adapting to get APPs, advanced the PAs or NPs, they can be part of our team. I think we are still challenged how to what would be the best structure to integrate APPs to our practice. And that's the same thing to our inpatient service. What's the best way to structure? What would be the best way to be neurologists work with neurology APPs? I think that's still challenge. And there's just many successful stories at the same time, might not be so easy from the beginning. And the patient experience are different as well. So I think we're still challenging on this.
Okay, well, thank you for your great insight, Dr. Lee. So one last question that we like to ask everyone is
Mhm.
what's your favorite part of the brain or central nervous system? And I guess for you, since you are a neuromusculist, we can leave it open for PNS also.
I would say it was a neuromuscular junction.
Sure. Well,
I
thank you
think
so
that part is always, uh, I wouldn't say been neglected, but I think that has some. I always say the PNS system, peripheral nerve, and the muscle, especially muscle. I think muscle is mostly neglected in a way. I think about the muscle is everywhere, but as an organ,
mm,
I think as pathology, as the myositis, myopathies, I think that part still need a that's the area. I think that'll be another big hit as well.
well, thank you so much, Dr. Lee. We
Mhm.
greatly appreciate it.
You're very welcome. This is fun. Thank you so much.
Yeah.